Hello, how are all of you? Now I'm going to make a little presentation about the seminar number 4 we will talk about now about early pregnancy bleeding. The bleeding general in pregnancy is very common and it's also a very challenging topic. And for us, all the doctors, we decided to divide these bleedings in bleedings before the 28 weeks and after the 28 weeks. So we're going to have two different seminars. One seminar about bleeding before the 28 weeks. This is the seminar number 4. And also the next seminar, that is the seminar number 6, will be about the bleeding after the 28 weeks. It's very difficult to make a correct diagnosis. There are a lot of different causes, but here in this presentation I will try to make it easier to classify, to diagnose, and to remember the different causes of this bleeding. So please, I invite you to put attention. As all of us know, bleeding in pregnancy is a very confused situation. It's a very confused diagnosis because have a lot of different causes, and each cause can be very harmful for the patient, have very difficult diagnosis, and most of the time we are like this man, like very confused, very like we have dizziness. Mimi nasikia kisungu sana. So that is how we feel when we have this type of patients and we don't know what to do, we don't know how to diagnose, and most of the time we ask for help or we try to search in the books. In the same moment with the patient there, we search on internet, but we don't know how to approach this patient properly. Here I want to share with you a proposal of a systematic approach for all of these patients, that it's not useful only for the early pregnancy bleeding, it's useful for all the bleedings during the pregnancy. So this proposal that I suggest is to approach the patient with 5 different questions that we're going to solve during this presentation. The first question is to know if the patient is stable or not. If we solve that question, we are going to ask ourselves, where is the bleeding coming from? And after we know where is the bleeding coming from, it's also important to ask ourselves if the patient is pregnant really or not. Or maybe she was pregnant and now she's not pregnant because she completed an abortion, for example. So it's very important to know if the patient is really pregnant or not. The fourth question, it's also very similar than the third one, but it's to know how many weeks of pregnancy did the patient have. And last question is, which is the specific cause of the bleeding? And in that question we're going to talk a little bit more, and we're going to classify, and I'm going to also share with you a few techniques or mnemotechniques to remember very good all the different causes of bleeding. So the first question that we said that we need to solve, and it's very important, is if the patient is stable or not. And how we're going to solve that question, and why this question is the first one, is the first one because if the patient is not stable, we are not able to diagnose or make further exams. We have to stabilize the patient first, because the life of the patient is in danger. So to solve this question is very important, first, the physical examination very fast, because maybe the patient is not stable, you are not able to talk with the patient, so you need to check if the patient is awake, open eyes, to check the ABC, if the patient have the open airway, if the patient is breathing, and of course to check the pulse. After that, if the patient like is good and you see the patient is awake, maybe you don't need to make the ABC and to check the pulse. But if you have doubts, it's better to check it. And after that, to check all the rest of the vitals, the heart rate, the blood pressure, also the temperature, and to assess the neurological status. If you don't know how to assess the neurological status, there is a summary about the ABD evaluation, or the Glasgow Coma Scale, in the class about shock. And if after all our evaluation we realize that the patient is not stable because there are low BPs, or maybe the patient have a low Glasgow Coma Scale, for example, we need to treat this, the cause of this. Maybe the bleeding is making an hemorrhagic shock. So we need to treat the shock first. We need to stabilize the patient, and after that we can make further examination or evaluation about all the bleeding. So which is the treatment of hemorrhagic shock? I invite you to please put in pause the video and try to write down in a paper, step by step, what you would do if you have a patient, if you are in front of a patient that is not conscious, and it's also bleeding, and it's not responsive, and have very low BPs, but it's not in a CPR. The patient have pulse, but it doesn't respond. So what you do in that situation? Please write it down, and you will have the answer in the next slide. So the initial treatment for an hemorrhagic shock are in order the following. First, the assessment of the ABC and give oxygen. After that, ask for help, or in the same time, in the same moment, ask for help, because you cannot manage this patient you by yourself. And strictly monitorization. Ask someone to take the vitals, urine output, mental status, and very fast try to put 2 IV lines to restore the blood loss and the fluid, the volume lost. So you put 2 thick IV lines, you take blood test, blood group, and cross match, because maybe you will need transfusion. Also, estimate the blood loss and perform a fast volumization. To provide volume, it can be ringer lactate, or also it can be normal saline. The importance here is to give it warm and use the rule 3-to-1. So for every 1 liter of estimated blood loss, you have to give 3 liters of normal saline or ringer lactate. After that, immediate control of external hemorrhage. If you're a team, as I said to you, you need to ask for help. If you're a team, you can ask another person while you are doing all the estimated loss, alone calculating and trying to restore the volume. You can ask two other persons that make compression to stop the bleeding, depending on where is the bleeding coming from. But in this situation, it's gynecologic bleeding, so it's very difficult to make a good compression. And the specific management according to the type of bleeding. For example, if it's APH because placenta abruption, you need to move this patient to theater very fast and try to achieve hemostasia. Maybe she will need a hysterectomy, maybe only a cesarean section and manual removal of the placenta. The fact is that you need to make a specific management, and that management must be fast. And also, with all the previous points, it's important to prepare for transfusion if you need it. The rule of transfusion is to give 1 pint of red blood for every 3 liters given to the patient. This is, we can discuss about this. There are some indications that are not these ones, but this is like the general rule in the place where I learned this in my country. But maybe here in Bagari you have a different indications for transfusion depending on the availability of the red blood cells. And of course, the most important that all the people forget, and I encourage you to remember, is the continuous evaluation, because these patients are severely ill patients and maybe they need further evaluation for other people. Maybe they need a continuous reevaluation every 5 or 10 minutes, because maybe they can change. They can get worse, they can have a CPR, or they can get better. So you need to make a continuous monitorization. So that's all the answers. I hope you can you have written down all of these ones. If you have not, I encourage you to memorize all of this treatment, because it can be part of the final exam. So now that we have solved the first question about the patient, if the patient is stable or not, we can go to the second question, that is, where is the bleeding coming from? Where is the bleeding coming from? To know that is very easy. You only have to use your eyes. So you do the genital examination, like only with the eyes, to check if there is bleeding coming out from the vagina or not. Maybe the bleeding is coming out from another place, from the anus, for example. If the bleeding is coming from the vagina, you need to classify this bleeding, knowing if the bleeding is coming from inside the uterus or the bleeding is coming from another place. And to do that, it's very useful, the speculum examination. With the speculum examination, you will see if the bleeding is coming from the os, you are talking about uterine bleeding. But if the bleeding is coming from another place, for example, the vaginal walls, for example, you have a wound in the posterior fornix or something like that, you can say that is cervicovaginal bleeding. Also, it's very important that when you do the speculoscopy, you need to check if there is active bleeding or ancient bleeding. That definition also is very important. And of course, that all of us know that when we have a patient with PV bleeding, we cannot do a vaginal exam. We need to do a speculoscopy, and the vaginal exam, you only perform it after ruling out the placenta previa. So the following question is the patient really pregnant? And here I want to ask you again, how do we know that a patient is pregnant? Which things are signals that show us that the patient is pregnant? We have signs in the clinical history, also we have signs in the physical exam, and we have other tests that can confirm our hypothesis. So I invite you to think a little bit about this. If you have time, please pause the video and write it down, so you can try to prove yourself if you know all the signs of pregnancy. We have a lot of different signs. By the history, of course, the amenorrhea. The patient stopped the periods. It means that something is happening. It can be pregnancy, the most common. Also, the symptoms that occur during pregnancy, that is nausea, vomiting. Also, she can feel fetal movement perception. That is another symptom that can occur in the primigravida, in the week number 20, 22, and in the multipara, in the week number 18. Also, the history of a test pack positive or maybe a scan that show a pregnancy, it's also very important to ask the patient, because maybe she have already that type of exams. By physical examination, of course, when you feel the gravid uterus, when you palpate, you can check that. And there are a lot of different non-direct signs, for example, linea alba pigmentation, a lot of different things that you can see in the skin, and that are product of the increase of the hormones. And to confirm, because any one of the previous ones are very safe, to confirm you need to ask for a urinary test pack and a quantitative HCG or a scan. Each one of these three by themselves can confirm the pregnancy. So, which is the hormone that we try to detect with these exams? Is the beta HCG. This hormone is created by the placenta, and this hormone make that the luteum body continue producing progesterone in order to maintain the pregnancy. Because if this hormone doesn't rise, the human chorionic gonadotrophin, the progesterone wouldn't maintain, and the corpus luteum eliminate the quantity of progesterone, and occur the menstruation. After this day, the menstruation and the pregnancy will go. So the role of the human chorionic gonadotrophin is to prevent that, and also a lot of different more functions. But this hormone is the hormone that also make a lot of symptoms to the mother, like nausea, vomiting, and is the hormone that we detect with the pregnancy test pack. So now we have solved the three first questions about if the patient is stable, where is the bleeding coming from, and if the patient is really pregnant or not. But now we're going to check about how many weeks of pregnancy did our patient has. And to diagnose that, we have a lot of different tools, and we're going to talk about a little bit about each one. So how many weeks the patient have? That is the gestational age, the current gestational age. To know that, we have a lot of different tools. The first one is a tool that is based in the clinical history, that is the LMP, the last menstrual period of our patient. It must be safe and trustworthy. Those are two characteristics that we need to have in our LMP to believe that LMP. If we don't have safe, or if we don't have trustworthy, we wouldn't be able to believe that LMP and that can be fake. So we need further things to diagnose a gestational age, for example, a scan or something, because that LMP is not real. So safe and trustworthy, what does they mean? We're going to talk about a little bit about this in the next slides. Here I give you a tool that is a link of a web page where you can put the gestational age, and the web page gives you the gestational age exactly with days and everything. And if you don't have this, or you don't have a phone with internet, you can use this wheel. That is a wheel that we have in the ward in the hospital. That is very easy to use and very fast. And you put the LMP, and you move the clock and find the date of the current day, and you will have the gestational age. So now I have a very difficult and very interesting question. I want you to answer it, read it, and then I will give you the answer. The question is, which is the best way to know the gestational age? A, with a safe and trustworthy LMP. B, with an early obstetric scan. C, with the third trimester obstetric scan. D, with fundal aid. Or E, any of the previous. Please put in pause the video and try to think which of the following is the most accurate and more specific way to have the correct gestational age for our patients. So the correct answer is the letter A. And now I'm going to show you why that is the best and the most accurate way to diagnose the gestational age. And also I'm going to show you all the other tools that we have to diagnose the gestational age of our patients. So we talk about that the LMP must be safe and trustworthy. But what does it mean? What means to be safe? What does mean that the LMP must be safe, and what does mean that the LMP must be trustworthy? To explain that, I'm going to use an example. Let's think that we have two mothers, Faith and Charity. So Faith is not certain about the exactly day or the exactly month of her last menstrual period. She doesn't know. Or maybe you don't have a good communication skills, or maybe she is mentally challenged, or maybe you, for example, me, I don't speak very good Swahili and the patient doesn't speak English, so I cannot know. So that means that the LMP is not safe, because we cannot know because the patient doesn't know, or maybe we cannot communicate good with her. That means safe. And if the patient knows very good and she remembers very well, that means we have a safe LMP. Secondly, to be trustworthy, we have here Charity. So let's imagine Charity, she knows very well the day of her last menstrual period, but she was irregular before the pregnancy. All the times their periods come in different days and very irregular. So we don't know the exactly day of the ovulation, and also because of that, the LMP doesn't represent the correct quantity of days since the conception was occurred. Or maybe she was not irregular, but she was using contraceptive pills or the implanon. So the exactly day of the conception, of course, we cannot know. So that makes us don't believe the LMP, and that means that it's not trustworthy. So in these two examples, we have how an LMP cannot be safe and how an LMP cannot be trustworthy. So if both of them are present in the LMP, it means that we can believe the LMP. If the LMP is safe and is trustworthy, we can believe exactly the LMP, and its most accurate method. It's most accurate than a scan. So after diagnosing the gestational age by the history, by the LMP, we also have another useful technique that is according to the physical examination. And how we do it? Measuring the fundal height. There are two ways of measuring the fundal height. The first one is with the fingers, that is the way that we do it in Bagari. And every finger above the umbilical level represents 2 weeks plus 20. We have to remember that the umbilical level is always 20 weeks of gestation, and and the level of the symphysis is 13 weeks or 12 weeks of pregnancy. And the other way is to measure in centimeters, and there are some charts that we know according to the quantity of centimeters, we know the gestational age. So here I have another question for you. When we cannot believe the LMP, which is a more accurate to diagnose the gestational age? So here we are in the situation that the patient cannot say to you the LMP, or the LMP is not safe or is not trustworthy, or both. So we need accurate diagnosis of the gestational age. What we're going to do? So the first question is to use an obstetric scan before 15 weeks. The other is an obstetric scan, but now very late, in 38 weeks. The other is the fundal height. The other is the VHCG levels, or the last one, abdominal circumference. I invite you to put pause in the video and try to think which is the best answer, which is the most accurate method. The most accurate method is the obstetric scan before 15 weeks. And now, with another example, I'm going to show you why. So, before the example, I only want to show that the early scan before 20 weeks, defined as by the World Health Organization before 20 weeks, is the most accurate method after the LMP. And the late scan is very useful to have like an idea of the gestational age, but it's not as accurate as the early scan. Now I'm going to give you the example that I promised to you. So why the early scan is accurate? We have again Faith and Charity that are our examples. So Faith is 18 weeks of pregnancy, and she got an early scan at 18 weeks. And Charity is the same mother, the same pregnancy, but she had the scan at 33 weeks. So let's get an example that Faith, for example, got syphilis. She had syphilis. And the fetus developed a disease called torches that create a IUGR. Okay? And, or maybe, it can happen the opposite. The Faith got diabetes, and she develops macrosomy. The fetus developed macrosomy. Okay? And she continued the pregnancy, and she have again another scan. And she can diagnose the IUGR or the macrosomy. But in the other side, we have Charity, that she doesn't have an early scan, and she developed the same syphilis. And we take the scan very late, at the 33 weeks. So she had IUGR, but we couldn't be able to diagnose that. And we only diagnosed that she had 26 weeks of pregnancy. And that is an incorrect diagnosis. She had IUGR, but because of the late scan, we thought that she had 26 weeks of pregnancy. Or by the opposite, she can have 20 weeks of pregnancy because she was diabetic and she developed a macrosomy, the fetus. And by the scan, we saw a very big fetus, so we estimated the gestational age much more than the real gestational age. And we thought that she was 40 weeks, that she was postdated, and we induced a delivery, but the baby born in preterm. So all of that are consequences that we can have because of the absence of an early scan. So that is the explanation why it's so important, the early scan, and why is more accurate, the early scan, because you can measure the fetus in the first moment since the creation of the fetus, and that leads you to have a more accurate diagnosis of the gestational age and the real gestational age. And also you can prevent all of that mistakes that we can do due to incorrect gestational age diagnosis. So why is important the gestational age? It's very important in this chapter of the bleeding during pregnancy, because before the 28 weeks we have different classification than after 28 weeks. Before the 28 weeks we talk about early pregnancy bleeding, and after 28 weeks we talk about antepartum hemorrhage. Early pregnancy bleeding, we make a definition as any hemorrhage in a pregnant woman before 28 weeks, and antepartum hemorrhage, any hemorrhage in a pregnant woman after 28 weeks. Why is so important this division? Why we are going to talk about this division? Because this. Now I'm going to explain. Before the 28 weeks, as I said to you, we talk about early pregnancy bleeding. And before the 28 weeks, here in this setting in Bagari Hospital, Kenya, we talk that there is no fetal viability, because there are no very good MVU and the resources to keep alive a baby with that level of prematurity. So in this situation, we have to take care of the mother. And also, in the early pregnancy bleeding, we have very specific different causes of bleeding that are related more to a gynecological causes and to all the things that have to be like abortion, ectopic pregnancy, and we're going to talk about that in this class. But in the other hand, we have the antepartum hemorrhage that is after 28 weeks, and here there is fetal viability. We have to take care now about two patients, the mother and the fetus. And also there are other specific causes of bleeding that are not the same causes than the early pregnancy bleeding. So to remember this, we will have two different acronyms that are related to the religion, because here in Kenya I know that there are a lot of people that are very religious. So I decided to create this only to remember, only to have like a word to remember all the different causes, so we cannot forget never any one of the causes. So the early pregnancy bleeding, we have the acronym called AMEN, and in the antepartum hemorrhage we have the acronym called Mr. Pray. And the APH we are going to talk about in another seminar, but only for you to know that the word that we'll use to remember is Mr. Pray. And now in this class we're going to talk about Amen. So now we're understanding a little and we are not so confused. Mimi nasikia mzuri sana, because I'm going to explain you how to remember all the different causes of early pregnancy bleeding. So now that we know all the general approach to a pregnant woman that is bleeding, with all of these questions that we have solved, we're going to solve the fifth question, that is the most longest answer, about which is the specific cause of the bleeding, and also talk a little bit about the treatment of each one of those causes. So to classify all the specific cause of bleeding during pregnancy before the 28 weeks, we use the word early pregnancy bleeding, and are all of these four: abortion, molar pregnancy, ectopic pregnancy, and normal pregnancy. And also we have the gynecologic causes, that are causes not related to pregnancy, like vaginal laceration, vaginal neoplasm, vaginal warts, cervical polyps, cervicitis, cervical neoplasm, and we have a lot of other different causes that we're going to talk a little bit about them. So when we have a bleeding not related to pregnancy, as I told to you, we can divide it in vaginal and cervical. Vaginal can be laceration, neoplasm, any trauma, and of course the vaginal warts that can bleed sometimes. But in general, all of these causes, the vaginal causes, are little bleeding, and you will find in the speculoscopy the place where is the bleeding coming from, you will find it, and also in the gynecological examination. By the other hand, the cervical bleeding, it's also not too much, but can be more, and it can come because of polyps, cervicitis, or neoplasms. And there are also a lot of different more causes. So if we don't know the certain diagnosis, we need to refer the patient to a consultant. But if the patient is pregnant, maybe that cause must be solved after the delivery. And when we talk about early pregnancy bleeding, we will use the acronym AMEN, as I said to you, AMEN, because this helps us to understand all the causes of the bleeding in the first half of the pregnancy before the 28 weeks. And what means AMEN? Abortion, molar, ectopic, and normal. That are the 4 different causes of bleeding in the EPB. So first we're going to talk about abortion, or another word that the people use is miscarriage or early pregnancy loss. The definition of this is a pregnancy loss before 20 weeks of gestation, and like all the pathologies in medicine, we have to approach in a systematical way. So we're going to come back again to the systematical approach pyramid. First, we need to check the clinical history to assess a patient that we are suspecting abortion. So we have to ask of the symptoms. If she's bleeding, assess the quantity of bleeding, to know if she's spotting or she's bleeding more or less than a menstruation. That is a very good way to classify, to have an idea of the quantity of bleeding. Also, we can ask her if she have a previous scan that confirmed the pregnancy, or if she have a previous test pack of pregnancy, if she had pregnancy symptoms, if she have nausea. Also, to have an idea of the gestational age, we have to ask of LMP or perception of fetal movements. So that all of these things, in addition with all the history, for example, if she have diabetes or chronic hypertension, allergies or surgeries, all of that questions are the clinical history. After a very good clinical history, we need to perform a physical examination. So a good physical examination, it's important to ask. It's important, sorry, not to ask, to examine. First, the general exam, the BP, the temperature, the perfusion, if she's pale or not, the general neurological status. Also to check the uterine size to have an estimation of the fetal, of the gestational age. Also to check if the uterine size is more or less than the gestational age by date. Of course, the approach must start with a speculoscopy to check if the os is open or not, to check if there is active bleeding or ancient bleeding, and if the os is open, you can perform a VE. If the os is closed, you cannot do a VE. You have to go to an ultrasound, because this can be a pregnancy that have not lost completely, and maybe if you make a conservative management, you can go on with the pregnancy. So if you do a VE, you increase the risk of infections and also the risk of develop more bleeding. So that is the reason why if the os is closed, you cannot do a VE. And after that, you go to further other tests. The principal and most important one is the ultrasound, because with that you can check the endometrium size, to check if there is fetal implantation or not, and also to check if the fetus inside is alive or not. So you check the fetal head rate, the fetal size, and any other sign that can guide us to the correct diagnosis. Maybe it's not an abortion, it's an ectopic pregnancy or a molar pregnancy. So the ultrasound is very, very useful, and it must be part of the assessment of these patients. If we are in front of abortion, we have a lot of different clinic presentations. In summary, I give you this for you to have and read in the presentation, but I summarize this with an image. In this image, we can show all the different causes, all the different clinical presentation of abortion. So the first one is the 310 abortion, where we have vaginal bleeding or pain, any symptom of abortion, but in the speculoscopy, we will see a closed cervix, and we will see the fetus inside with cardiac activity. So this is not an abortion, it's only a threat of abortion, but the fetus is inside, is alive, so this can continue and can be a person in the future. We don't do a VE, and we do conservative management and analgesia. The other clinical presentation is missed abortion, where there is no vaginal bleeding and there's no symptoms, but we can diagnose this because the mother For example, is doing like a checkup ultrasound, a routine ultrasound, and the doctor realized that there is no fetal activity, no fetal movement, no cardiac activity. So it means like intrauterine demise, but now it's not after 28 weeks, it's before. So we call missed abortion. This type of patient normally say that they will feeling very bad during the pregnancy, like nausea, vomiting, and suddenly from 1 week to another they feel better. They don't have nausea, don't have vomits, because the pregnancy was lost, so the chorionic gonadotrophin hormone go down, and all the symptoms of pregnancy, like the nausea, the vomiting, go down. In these cases, you have to refer to a doctor. Sometimes you do expectant management to the fetus to go out naturally, and in other situations you have to open and do a dilatation and curettage and extraction of the product of conception. It depends on the gestational age and on the setting. After that, we have the inevitable abortion. That is when we have vaginal bleeding and the cervical os is open. So in this situation, we can do a VE to check how far is the patient, and the production of conception might be seen or felt at or above the cervical os. Very similar than this presentation, we have the incomplete abortion. In the incomplete abortion, we have vaginal bleeding, dilated cervical os also, and some product of conception expelled, but some of them remain. In the inevitable abortion, there are no expel of product of conception, only blood. So the gestational age by physical exam is the same than by date. But in this situation, we have expelled some product of conception, so the gestational age by physical exam is a little less than the gestational age by date. And here we have expelled some product of conception. That is the concept. And in the inevitable abortion, the fetus can be alive or not, but the process of abortion is on the way. So we have trespassed the point of no return, and the abortion is going on. So the treatment is to finish the abortion process, and you can do VE and all of that. In the complete abortion, we have vaginal bleeding or non-vaginal bleeding, but a history of the patient that had in the past a lot of bleeding, maybe more than a menstruation, or a lot of more, or maybe the patient will tell you that she saw a human figure, a human thing, like a little fetus. In this situation, the patient comes and the cervical os is closed in the speculoscopy, and the product of conception have been completely expelled. So if you do an ultrasound, you will look at the endometrium and it will be very little, like 13 millimeters, 15 millimeters. In this situation, only clinically is very difficult to diagnose, and maybe it can be only a threaten of abortion and not a complete abortion. So you need the ultrasound. You cannot do a VE. You need the ultrasound to make sure of that, unless you have the history of the mother that they have expelled the little fetus, and you can perform the diagnosis. So we have talked about abortion. Now we're coming to the M of Amen, that is molar pregnancy. A molar pregnancy is like a genetic anomaly during the fecundation that generates a fast and non-organized placenta growing. It's like a tumor of placenta that is growing very fast, that can be complete or incomplete depending if they have a little part of fetus or not. But both of them are unviable pregnancies. They will not live. So here the treatment is to take this away. It's a thing that is not very common, and it can be diagnosed by a scan. You will see like a snowstorm inside the uterus, and a lot of different vesicles inside the uterus. Or also you can do a direct biopsy of the vesicles if you have a sample to diagnose it. So here in this image we can see the vesicles of a molar pregnancy. It's something like this. I have never seen one, but this is the photo for you to remember. And also it's very common that this type of molar pregnancies have a very intense secretion of beta HCG. So the patient have a lot of pregnancy symptoms. She have a lot of nausea, vomiting, and also she can develop preeclampsia before the 20 weeks because there's a lot of symptoms of placentation. So the placenta can lead to a preeclampsia before the normal limit of 20 weeks. So here we have the third cause of early pregnancy bleeding, that is the ectopic pregnancy. The ectopic pregnancy means that when the pregnancy make the implantation in a place that is not the normal place, it's not in the uterus. It can be, for example, in the cervix, it's very uncommon, or in the cesarean scar. Also, it can be in the abdomen, outside of the uterus, or it can be in the fallopian tube. That is the most common, and the most common inside the fallopian tube is in the ampullary zone. This ectopic pregnancy occurs to the 2% of all the pregnancies and is very serious illness. It have a 10% of mortality, and commonly the mortality is because this pregnancy in the not correct place start growing and reach a point where this pregnancy have a lot of vessels and broke inside the mother and start bleeding a lot, like an internal hemorrhage, and the mother died because of a hypovolemic shock with an unclear cause. The diagnosis of ectopic pregnancy must be excluded in every pregnant woman with bleeding or every pregnant woman with severe or persistent low abdominal pain. It's a diagnosis that most of the time we can forget, or if we don't have the real tools to diagnose it, like ultrasound, maybe we couldn't find it. But it's very important to have in our mind, because if we have an emergency, a mother that is with signs of shock or maybe a syncope, we have to think about that diagnosis, and sometimes we need to perform a surgery without having the correct diagnosis, only to check in the exploratory laparotomy to check if there is or not ectopic pregnancy. So in which type of patient we have to suspect this? The patient that have risk factors. Also, the patient can have any risk factor and have the ectopic pregnancy, but the most likely to happen, the most common things that leads to have an ectopic pregnancy is to have a history of a previous ectopic pregnancy, or a tubaric surgery, or any surgery that they have a manipulation of the fallopian tube, or a demonstrated tubaric pathology. All of those ones are high risk factors. Also, we have moderate risk factors and low risk factors that here I have, you can read it. But the most important are these three ones, and also this. The intrauterine Cooper device. This is an important risk factor that makes chronic inflammation inside the uterus, and also they make a change in the fallopian tubes. Of course, this decrease the global risk of pregnancy, so decrease the risk of ectopic pregnancy. But when you get pregnant with an IUCD, you have a lot of risk to have an ectopic pregnancy in the fallopian tube. The clinical manifestation of ectopic pregnancy are all the signs of pregnancy, because this can start like a normal pregnancy with amenorrhea, with nausea. So the patient will think she's pregnant in a normal pregnancy. So she will go to the antenatal care, maybe they will ask an ultrasound, but she doesn't have money, so she will never know that she's having an ectopic pregnancy. But in some moment, soon or later, she will have low abdominal pain, pelvic or abdominal pain that can be localized. Then she will develop tenderness, localized tenderness, and PV bleeding. This PV bleeding is not because the pregnancy is in the uterus. This PV bleeding is because the endometrium of the uterus have modification because of the increasing of the hormones of the pregnancy, and this endometrium start going out, and that leads the PV bleeding. If there is no symptoms, or the mother have only a little symptom and she never go to the hospital, she will go to the hospital maybe because of a rupture. But in this situation, this is a very severe situation, the mother will have signs of hemorrhagic shock, as I said to you, also can present with a syncope. And this type of presentation is very serious. The mother also can die. So how do we study this type of patients? First, we have the laboratory tools, that is the quantitative HCG. If the HCG is more than 1,500, we can see the pregnancy with intravaginal ultrasound. And when it is more than 2,000, we can see the pregnancy with an abdominal scan. So, for example, if we have a patient that have 3,000 of gonadotrophin chorionic, it means that if we do a transabdominal exam, we will be able to see the pregnancy inside the uterus. If we don't see the pregnancy inside the uterus, we are sure that there is an ectopic pregnancy. And also, the same occurs with the intravaginal ultrasound. So if we have, for example, 1,800 of HCG, we must see the pregnancy with this transductor, the vaginal transductor. We must see the pregnancy here, in some place inside the uterus. If we don't see anything, and we have 1,800 or 1,500, it means that maybe the pregnancy is ectopic. Not always the ectopic pregnancy you will see it with the intravaginal ultrasound. Maybe it's hidden in some place, so it can be in any place. There are some kinds of pregnancy that are implanted in the liver, for example. It can be very far away, so you will never know. And which is the management of this type of patients? It's always important to admit. You will never be able to manage this patient or study this patient as an outpatient. Always you have to admit, because this patient can complicate in any moment. And you have to perform an evaluation by a consultant. Here you need the help and the counseling of a consultant, so you can manage this patient by yourself. The definitive treatment is, it can be a surgery or a medical treatment. It depends on the size, if there is or not a fetal heart rate, and different management. But this is not sort of the clinical officer. So the thing here is to refer and to perform continuous monitorization in case of the patient can complicate. But the definitive treatment will be done by a consultant. And after the ectopic pregnancy, we have the N of Amen, that is normal pregnancy bleeding. There are some times in a normal pregnancy that in the first weeks the patient can bleed a little, but it's only a kidogo, like this photo, kidogo bleeding. That is the most important characteristics. If the mother bleeds a lot, more than a menstruation or a lot, you need to rule out all the other things. And it's important to say that this is a diagnosis of exclusion. You need to exclude all the other diagnoses, and when you rule out all the others, you can say that this is a normal pregnancy bleeding. So you have to perform a story, a physical examination, a speculoscopy, intravaginal ultrasound, and if all of that is normal, you're talking about normal pregnancy bleeding. So you rule out the A, that is abortion, you rule out the M, that is the molar pregnancy, and you rule out the E, that is ectopic pregnancy. The most important to rule out is the ectopic pregnancy, because this can complicate and can be very serious to the mother. Okay? And as I said to you, a small amount. Kidogo, the blood. It can occur during the 10 or 14 days after the fertilizations, and the people think that the cause of this bleeding is because of the implantation process. So now that we finish our class, the little golden potatoes, the take-home message of this class is that the PV bleeding during pregnancy is a very common complaint, first of all. Secondly, when we have to approach a PV bleeding in pregnancy during any moment of the pregnancy, we need to approach this with these 5 questions. First, to ask ourselves if the patient is stable or not. If it's not stable, make the treatment of the shock to stabilize the patient. After that, ask ourselves which is the site of the bleeding. After that, if the patient is really pregnant or not, and the gestational age. And the last question is about the specific cause, because that will guide you to the real and the correct treatment. The other message important is to remember that all the causes of early pregnancy bleeding, we can solve it with this word, that is Amen. So don't forget the word Amen. In Swahili you say Amina, but must be in English because these are the correct letters, A-M-E-N. And it's always especially important to rule out the ectopic pregnancy in all the early pregnancy bleeding and in all the early pregnancy that have signs of shock or have, for example, pain. And without bleeding, it also can be an ectopic pregnancy. And the other message important is that the pregnancy test pack and the intravaginal ultrasound are essential tools for the diagnosis of the early pregnancy bleeding and to roll out all the differential diagnoses that we can have in our mind. And as always, you need to ask for help because all of us are only clinical officers or simple general practitioners. We need the help of the others. We need to work as a team. So ask for help is the key of the success and to evaluate continuously the patient because this patient can change time by time. Thank you for everything. I hope you like the presentation. I hope I'm not too long for the classes. Please send me a message. Any question you have, you can send to me. And asante sana.